If you see the surgical definition wise, we know that it's been done in patients who have inadequate ventricular size and volumes. There will be lack of independent inflows, unable to establish adequate LV outflow, and inability to establish two independent functioning ventricles in circulation, supporting series. So this is in general the definition of univentricle repair, and there have been lot of changes from initial description of Fontan to modified Fontan, lateral tunnel, and extracardiac Fontans. If you see the different anatomic variants of univentricle, they are tricuspid atresias, unbalanced AV septal defects, DORV with remote VSD, double inlet ventricle, hypoplastic left heart, pulmonary atresia, intact septum, and multiple varieties of heterotaxy. And when we talk about single ventricle palliation, what are the strategies? We have to establish balanced parallel circulation. There may be situations where there is significantly reduced pulmonary blood flow presenting with cyanosis. There will be significantly or excessive pulmonary blood flow, which happens with excessive pulmonary blood flow or obstructed either systemic or pulmonary venous blood flow or duct-dependent systemic circulation. So early surgical palliation in neonatal life is required in patients either in the form of pulmonary aortopulmonary shunts, PDS stents, or a DKS-like procedure in hypoplast variants, or pulmonary artery banding. In addition, repair of systemic outflow, repair of pulmonary venous return, or wide atrial septectomy. And echo assessment after prior to the first stage, I think echo assessment is the crux of managing these procedures. We need to know what is the size of ASD, especially in patients with mitral tricuspid atresias. Are the branch pulmonary arteries confluent? How is the pulmonary venous flow, whether there is any obstruction? The most important, whether there is any systemic ventricular obstruction. How is the ventricular morphology and function? How is the ascending aorta and coronaries, especially in patients with hypoplast? And how much is the degree of AV wall regurgitation? As we know, the left ventricular morphology is always better for a single ventricle palliation as compared to the right ventricle because of its fiber arrangements, coronary flow reserve, and degree of AV wall regurgitation. I hope it works. So this is a patient with actually a single ventricle with a transposition physiology, and this is a bulboventricular foramen which is quite restrictive as compared to the other video. If you see, the bulboventricular foramen is quite well open. And it's very important to assess the bulboventricular foramen adequacy prior to a univentricular size. We have to image in parasternal long axis and short axis, and there is a formula which is pi into diameter 1 and diameter 2 divided by 4. And if your foramen oval or a bulboventricular foramen is more than 2, it is non-restrictive. It is less than 1, it is significantly restrictive. So it's very important to assess the adequacy of bulboventricular foramen, because otherwise it can potentially cause a subaortic obstruction. At the same time, for a univentricle repair, it's very important to see the sizes and the confluence of branch pulmonary arteries before doing any palliative procedures. Now this is a patient with a hypoplastic left heart syndrome, and then you see the interatrial communication. It's very restrictive, as in one of the risk factors for doing surgical repair for a hypoplast, because we need to have a wide atrial septectomy, because otherwise it will increase the pulmonary venous pressure. Again, it's one of the risk factors. As compared to this, you see this is a tricuspid atresia, but very large interatrial septal defect. And these are one of the things which need to be carefully looking on echocardiography prior to doing the palliation in these subgroups. Maybe additional CT imaging is required in some group of patients if we suspect any abnormal pulmonary venous return, size and confluence of the branch pulmonary artery is a concern, if aortic arch obstruction is a concern, and if there are any additional aortopulmonary collaterals. Now, after doing the first stage, either it is a pulmonary band or a DKS-like procedure or a systemic to pulmonary artery shunt, comes to the next stage, that is a bidirectional Glenn shunt, and they need to be assessed carefully again on echocardiography with size of interatrial communication, pulmonary artery anatomy, How is the BT shunt functioning? If there is a pulmonary artery band, if the band is adequate and it's not distorting any of the branch pulmonary artery, how is the DKS anastomosis, and what's the degree of AV wall regurgitation? And these points are very, very important before planning the second stage, that is a bidirectional Glenn shunt. And this is a patient who is a post pulmonary artery band for a univentricular heart, and we need to see the adequacy of the band, whether there is enough gradient and the pulmonary artery pressure can be near normal. And this is a band gradient, and see that the interatrial septum has a wide interatrial communication. At the same time, if there is a shunt, we will have to see the shunt, the branch pulmonary artery confluence. Especially in patients who have undergone any kind of a procedure for hypoplastic left heart with a arch obstruction, it's very, very important to define the aortic arch anatomy very well. And if is there any doubt, then we may have to do a CT scan to assess the aortic arch anatomy. So prior to Glenn, branch pulmonary arteries need to be evaluated carefully to see whether there is any pulmonary artery distortion, interatrial communication, additional aortopulmonary collaterals, pulmonary artery band gradient. If there is any systemic venous abnormality like bilateral SVCs or interrupted IVCs, need to be seen carefully. Pulmonary venous anomalies, again degree of AV wall regurgitation, ventricular function, and size of bulboventricular foramen. So this is the echo which subcostal view, which shows that there is a IVC is interrupted and it's going up as a zygous continuation. It needs to be seen very carefully because this patient should undergo, or they will undergo, a procedure called as a Kawashima procedure, and needs to be defined carefully. Most of the centers or many centers may prefer cardiac cath prior to Glenn, especially if they have undergone a palliative procedure before doing a Glenn, either a pulmonary artery band or a BT shunt. Again, all these parameters need to be assessed. I think there's a next talks, I won't go in details for that. So this is I'm just imaging wise showing a angiography of a patient who has a BT shunt. It's very important to see the pulmonary artery anatomy, and it's also important to see the pulmonary artery pressures and pulmonary vascular resistance. Post pulmonary artery band, we had to check the pulmonary artery pressures and again see if the is there any pulmonary artery distortion after the band. It's very important to see whether there is a single SVC or there are bilateral SVCs, because the surgical approach, whether it is you need a right Glenn or a bilateral bidirectional Glenn, need to be decided by the surgical team. So it's always very important to demonstrate if you are doing a angiography, and especially in patients with situs ambiguous, it's important to define the systemic and pulmonary venous drainage either by angiography or by CT scan, because your positions of SVCs and IVC may be completely abnormal in patients with heterotaxia, and their surgical approach may change accordingly. Now, another thing which is very important to consider, especially if you have a hypoplastic tricuspid wall and hypoplastic right ventricle, whether the patient should just go for a single ventricle, bidirectional Glenn-like shunt, or we can have incorporation of the right ventricle and can consider for 1.5 ventricle repair. And assessment of tricuspid wall and the right ventricle is very crucial for this kind of a decision. And this is a patient who has a hypoplastic tricuspid wall and a right ventricular cavity. This is an assessment done on angiography, but there are simple formulas on echo. How do we assess is depending upon the tricuspid wall Z-score, whether it is less than -2 or normal range, or more than -2. So depending upon -2 to -4, or less than -4, depending upon that we can assess the RV cavity and take a decision depending upon whether you need to go for a 1.5 ventricle repair. And after the Glenn, it's a pre-Fontan echo evaluation. Again, we have to assess the Glenn shunt, best seen on suprasternal view, see for Glenn flow, but see for the decompressing vein, because that again tells you either your pulmonary arteries are distorted or a pulmonary artery pressure may be on the higher side. Is there anomalous pulmonary or systemic venous return, systemic AV wall regurgitation, and the other most important anatomical features, morphology of ventricles, size of interventricular communication, size of pulmonary arteries, ventricular functions, and AV wall regurgitation. So this is our right side. You see a smooth flow across the gland without any distortion. But on the other side, you see there is significant narrowing at your SVC, RPA, anastomosis. And you know that's going to create a problem in the post-operative period or during the surgery as well, because we need to define or address the right pulmonary artery narrowing prior to surgery. Assessment of ventricular function prior to Fontan is a very important aspect of doing echo. Ventricular volume overloading always is a major concern. Ventricular hypertrophy is a major determinant of pulmonary blood flow, because you may have an increased LV and diastolic pressure, which may reflect into increased pulmonary venous pressure and pulmonary arterial pressure. It may cause increased wall stress and hypertrophy. There are inappropriate changes in mass and volumes, and preoperative measurement may help us thinking whether there can be any post-operative problems. So risk factors for Fontan completion on echocardiography: if you have pulmonary artery distortion, increase in the pulmonary artery pressure or PVRI, significant AV wall regurgitation, reduced ventricular function, ventricular hypertrophy, complex systemic pulmonary venous returns, and systemic outflow obstruction. And I feel personally in our practice, these may be probably unsuitable candidates for Fontan in heterotaxy with abnormal systemic venous return with severe pulmonary hypertension, univentricular heart with pulmonary arteries, atresia, non-confluent branch of pulmonary arteries which are hypoplastic, severe left AV wall regurgitation, dilated ventricles with poor ventricular function, and severe pulmonary hypertension presented for the first time at a later stage. This may be probably unsuitable patients for a single ventricle repair. And just a couple of pictures, and I'll just finish that. That was a Glen angio. It's very important to do a IVC gram to show them what is the drainage of the IVC, which side is the IVC. Post-op Fontan evaluation, the windows are very difficult, and many times if there is any issue, we may have to take the help of CT or MRI for delineation. And these are the possible complications which can happen and which may need to be addressed post-Fontan. And some of the centers may even do MRI just for a pre-Fontan evaluation. Most of the centers of ours still prefer to do a cardiac cath and angio. And sometimes for planning of Fontan, MRI evaluation is done to see the cable contribution to pulmonary blood flows. So thank you very much.